My name is Paul Newkey. I'm the Global Health Editor at The Telegraph. And we're here tonight at the Best for Britain offices to discuss the APPG's report on long COVID. It was launched just 2 months ago. I'm here with three guests. Layla Moran, who is chair of the committee and has been from the very off. Dr. Dan Poulter and Debbie Abrahams, both vice chairs of the committee. So we'll kick off, Layla, with you. If you could tell us a bit about why it's so important for people living with long COVID that the report has been produced, and tell us a bit about what the response has been to it.
So first of all, thank you for chairing this, Paul. It's so appreciated. And actually, the top thing that we keep hearing from people is that they feel forgotten, that they feel that their voices aren't heard. And I'll never forget the very first hearing we had on this, which was actually way back in that very first summer. It started to emerge, particularly from NHS workers who got COVID in the very early days. From about July, August, we noticed something was happening. And they were reporting that even quite mild symptoms at the beginning were leading to really debilitating symptoms that were stopping them outright from working. So, of course, as a committee, we're deeply concerned because this is the height of the pandemic response. We need every single medical person we can on that front line, and yet they're being taken out. The other thing that was really striking about it was the number of people who said, they used to bike 20 miles to work every day. They're in their 30s, fit and healthy people before. Very different profile to the sorts of people who were getting the worst symptoms of COVID itself. And just the fact that we are maintaining our focus on it 2 years on now, we've held backbench business debates on it. And in every single time we've done it, we've tried to raise their voices. But it's huge numbers of people, Paul. It's 1.8 million people at the latest ONS survey, of which about 750,000 of them have had it for more than a year. So when you have something as debilitating as this for more than 12 months, you are looking at that point at it being classed as a disability. And it's really significant for the workforce and the country as a whole.
So they're quite big numbers, 1.8 million people who have had symptoms for more than 4 weeks or about 4 weeks, and
784,000 actually. So it's huge numbers
for
more than a year.
Yeah.
And then 74,000 more than 2 years. But the thing that's significant about those long-term figures, if you look at the graphs of them, they aren't going down.
Right.
And as the cases rise, and again, what's really important to impress on people is that even asymptomatic cases of COVID can lead to long COVID that are symptomatic. And so we thought from very early on, if the government had communicated this, particularly to young people, it would have been an incentive for them to get vaccinated, because it is also true that if you get vaccinated, it lessens your chances of getting long COVID. We genuinely think the government has missed a trick in the early days from talking about this. And the fact that they still, I don't think, are properly taking this seriously. It's slowly moving. They started using the words long COVID. They've got some money for research. I'm not going to say they've done nothing. It's just absolutely not true. But we do think they haven't done enough, given the enormity and scale of the issue.
Right. And Dan, maybe I could ask you, tell us a little bit about the symptoms that these people are suffering, because it's quite a range, I think.
Well, a hugely variable number of symptoms. I mean, fatigue is one that's often called brain fog. So people almost presenting as if they have early cognitive decline in quite young people, sort of, a bit like dementia at a younger age.
Yeah.
People have, muscle aches and pains, tinnitus, a whole range of symptoms, shortness of breath, chest pain.
Yeah.
But there's no doubt that in the group in particular of people who have long COVID, when it lasts for many months and into years, that it's debilitating and affects many aspects of their day-to-day lives, their ability to socialise normally, ability to work, and it also has therefore an impact on their mental health and well-being as well. So we're dealing with fairly large numbers of people with a wide range of symptoms, but people's lives who have been considerably changed, much for the worse for the fact that they've had COVID.
Right. And Debbie, sorry to put this on you, but you've had COVID a couple of times and know a little bit from 3 times.
Yeah.
And know a little bit about how the symptoms can hang around.
Yeah, absolutely. So I had my first very mild dose. I think all of us have had it, but I hardly had any symptoms for about 4 days. Slight sniffles, no cough at all. I felt very tired, bit of a fever, a bit achy. Then it seemed to clear, and then I got nearly all the symptoms that Dan has mentioned. Particularly the pain, the body pain. So
Quite a lot of people talk about that.
Yeah, I mean, it was. I was a very active person. Used to do a lot of running, and now it was affecting my ability to walk. I literally was sort of moving like a statue. It was moving like a statue. I was very, very stiff, and it was difficult, but also. Digestive issues as well, which I think particularly young people are saying that they're having some nausea and vomiting, diarrhea, and that sort of thing. Yeah.
So certainly people I know from the office, talk about those symptoms and others, shortness of breath particularly, and that it seems to come back. It seems to clear with some people and then come back again weeks or months later. Is that something that the committee has heard?
Absolutely. So that relapsing, remitting aspect of it, which is mimicked, and there are other conditions that do the same thing, is particularly problematic because particularly for those people who have lost their jobs, and we keep hearing stories about people who have lost their jobs or have come under disciplinary pressures at work as a result of long COVID, teachers, doctors, people who you'd think you'd want to sort of keep in professions. And they then say, well, they struggle to access benefits because of the relapsing, remitting nature of it. So they will go and they will describe their symptoms and get rejected for benefits relief. And so part, I think, of the battle here is not just to find, what are the solutions medically, but actually how do we support people and people do recover. I think this is an important point of hope. There will be people who are watching this who perhaps have it or are worried about loved ones getting it. There is a proportion of people who, with help, definitely get better. There are treatments out there that, if you can access them, which perhaps we'll get onto later on, it can get better.
But at the moment, a really important message,
the benefit system doesn't seem to recognise that, and we need to get employers the guidelines they need to understand that as well.
I think that's the key thing. I was quite shocked, I have to say, hearing some of the evidence that we all heard about how employers were treating people, basically, especially in former NHS employee and so on. I really found it difficult to understand how the NHS was treating some of our healthcare workers who, nobody wants to be ill. This, and I think we've been talking about this before about being believed, that these symptoms are
being
real.
Taken seriously.
Yes. An awful case about a teacher I remember who was literally dragged off her sickbed, wasn't she? And dreadful.
So I've since had a meeting with Nadeem Zahawi due to the report that we released, and he was really shocked. And so I think the message that we need to get to ministers is that actually there is a workforce issue in every single department. They really need to now grasp this nettle.
Okay, so let's move on a little bit. Dan, can you give us a bit of detail about the report produced by the committee? There's a lot of detail in it, including the key recommendations.
Well, yeah, so there are a lot of recommendations in there, but I mean, two sort of headline points would be, firstly, for the government to commit to proper funding, so £100 million worth of funding. There was some upfront funding to support sort of research and the like, but that needs to be sustainable, long-term funding and of a sufficient amount that's going to make a difference. And then secondly,
for scientific research.
Yes. I mean, to back that up, and there has been some good research, and what that research has done is it's helped to outline the fact that this is, that there is, a chronic inflammatory process going on in many people's bodies. Now, of course, some of the people who have long COVID will be those people who are in intensive care and have got horrendous scarring of their lungs and long-term damage from being from having a very severe case of COVID. But the vast majority that people we're talking about here are people who have biomarkers that suggest chronic inflammation. So there's a biological process going on here, so the research and the money that's gone into this has helped that. But what we now need are, we need more research. We need proper care pathways, and what we don't have in this country, is the same priority being given to develop care pathways for people with long COVID. So people may get, for example, one appointment, but then they're just pushed back into the normal NHS system. We need to think about how this looks for people with long COVID in terms of physical health care, but also, the psychological support that's needed for people with longer term conditions, and that's also an important part of people's recovery.
On the funding for science to research a condition, is there a sort of systematic plan for how that research should be rolled out in much the same way as, Britain led the world really in, testing some of the treatments through the React studies? Yeah. Is there a plan? Would you like to see one?
It'd be good to see one, but I don't think there isn't really a plan. I think that's the concern. I mean, I'm sure Layla and Debbie will talk to this in a moment. But there is I think all of us feel that the government has put some money there. There has been some good research, but there isn't really that sort of long-term plan or understanding about how services need to look, and indeed what the long-term need is for research funding, or indeed for supporting research funding that will benefit other chronic conditions. So we've heard about some of the similarities between long COVID and other long-term chronic conditions, and some of those have elevated inflammatory biomarkers as well. So that funding actually, could bring tremendous benefits if it's sustained for a whole host of conditions. But obviously the main focus for us at the moment is long COVID.
Debbie, on the pathways themselves, in the absence of really thorough science and conclusive science, what sort of pathways are medics and public health people running at the moment to help people with symptoms?
So there is a nice guidelines in terms of care and treatment protocols that should be followed. But I think what Dan said is absolutely right. We're really a little bit working in the dark here. We have limited understanding in what's happening in long COVID in terms of the inflammation that Dan's referring to. We don't know that, for example, if that's down to our immune systems not working appropriately. And so we need to have an understanding then in terms of the immunological aspects of the disease and how they're working, and what other aspects of treatment might be brought in. So then we need to understand how it's working, the systems that it's affecting, because it goes right across all the body systems, because the epithelial cells that are affected, that are latched on by this virus, are very, very widespread, and then how we can deal with it. But on top of that, we need to also be monitoring it, and I think this is something that we haven't. Obviously, the ONS study is doing that, but how, for example, long somebody may have long COVID symptoms. I know, for example, in China, they have done a 2-year, the longest study so far, 2-year study on over 2,500 people. And we need to be replicating that sort of work here, and then comparing, sharing our data internationally as well.
I guess one issue at the moment, just from the point of view of someone with the condition, is just getting through to a GP or a medical professional of any sort at the moment. It's pretty difficult, right?
It's really sporadic as to whether or not you have a good level of service or not from the NHS. And I think this is one of the things that we point out in the report. There are cases where, you've got a brilliant GP who's on it, who's really sort of understood this. By the way, especially early on, this was not the experience of many people. They'd go to their GPs and they were sort of rebuffed. I think it's getting better, but there is still a lot of education that still needs to be done. And it was really helpful that the British Medical Association is fully, on board and has been conversing with us, and then accepted that this was happening, and is now campaigning alongside us to get more done out of government. I think that was really important. But the other thing that then happens is different parts of the country have different ways of commissioning long COVID services. So, for example, in Wales, they don't have any long COVID clinics at all. They prefer to manage it within the current system. Pros and cons to that. I'm hearing from many patients that's a con, because they if their GP doesn't then refer them on within the current system, they have nowhere else to go. In England, it really depends on your region. And so the patchiness, whilst the government will point to, well, your X number of long COVID clinics, and we're doing all of this stuff, actually the anecdotal evidence that we're getting at quite high levels from patients is that it is really patchy across the country. Or, as Dan pointed out, they might go, they'll get one appointment, they'll be given a book and they're there. And actually to access any kind of ongoing treatment is really, really difficult.
Are there centres of excellence that any of you have come across?
I'd like to say Oxford is, but that's not surprising. They have engaged heavily with me, and actually they're a centre of one of the research studies, so that's not really surprising. But I don't want a centre of excellence. I want everywhere to be, everywhere to be that centre of excellence. And there are places that are doing amazing things, but also abroad. And I think Debbie's point around there are other countries that are doing this better.
Well, you should look around the world for sure.
Indeed.
Internationally?
Internationally, well, patients report to us that when they struggle to access services here, Germany is somewhere that they're going where there are other ways that they're approaching it. They seem to have a much more robust response to long COVID there. A few more experimental treatments as well. And so when people sort of are at their wits' end, they are self-funding, if they can afford it, very often, to go to places like Germany to access that next level of care, which I think is a real shame. We should be able to do that here.
So I guess in part, it's going to be countries with significant capacity, healthcare capacity, who have invested previously in health services that are going to have greater ability to do this, right?
Yeah, and I think the story from Germany, and I think this was quite early on, we heard, there were some countries that did this better than others in general. They realised that to invest early paid a dividend later on, and I think this is what Germany's realised. I think the NHS has realised there's a problem. I keep hearing from ministers, Sajid Javid expressed concern about long COVID and claims to take it very seriously. But in terms of the system itself, I don't think it has responded in quite the same way.
Hasn't it? I mean, it really is under Dan still, actively engaged in the NHS, but the system is absolutely stretched to capacity.
Yeah.
I can't, speaking to former colleagues and so on, they're at the wit's end, and when colleagues are still being laid off because of being poorly and having to fill in for them, it makes it incredibly hard. You just feel as though you're running sort of 2 steps forward, 3 steps back sort of thing.
So I wanted to ask, so you're a fellow of the Faculty of Public Health.
Sounds grand, doesn't it?
Right. It is grand, it is. But tell me, how do you think the medical community is responding, both to the idea of long COVID being something that needs to be taken seriously, and also their ability to respond and help?
I hope that it's recognised that this is a significant and complex and varied illness. Different patients may present in different ways, but I hope we've learnt the lesson, particularly around how people with chronic fatigue syndrome and ME who were dismissed, and we know now that these are legitimate, genuine diseases that need our compassion, but also our active engagement in how we can work with them with patients to resolve these issues.
Are you optimistic that the medical community will embrace this one?
I am. I think there's a yes. I'm an eternal optimist.
Okay. So some of the bigger talking points. So long COVID has had a terrible impact on the workforce. I think all of us can see that just through our day-to-day work. What have you heard from employers about how it's impacting them? And do you think does it point to changes for the future of work? Dan, you go.
Yeah. So, I mean, I would say certainly in the NHS, there are a significant number of medical colleagues that I'm aware of. I mean, one or two actually who almost certainly died of COVID, and others who have have had COVID, and most of us have been on the front line and more prone to catching it. And there are some who have gone on to develop long COVID. Now, the response has been different from different medical employers, because each part of the NHS is quite independent. But on the whole, I mean, certainly my own experience is that there has been good understanding of people who have been who've experienced long COVID, and there's been good support, but that hasn't been universal throughout the NHS. And there are some stories of people who have effectively now been effectively made redundant by their NHS employers, and that is not a very good place or an acceptable place to be. And I would like to think that may be down to the fact that there was a poor understanding of long COVID in the early days. But the NHS of all employers should be the one that's setting an example here about how to care for people with long COVID. Some do it well, but
there's about 400,000 people who are no longer working because of health factors relating to the pandemic. Now, not all of those will have long COVID, but it does include those. So it's going to have an impact on the economy. I don't know. You might talk a little bit about why an investment now may actually pay dividends later, with that in mind.
Absolutely. So I think it's a third of small businesses have at least, they reported that the greatest reason for anyone being off long-term sick was long COVID. And as we know, in a small business, that's a really hard thing to manage when you've got small and micro businesses. The NHS itself was patchy. I think it was locums in particular that were sort of forgotten very early on. But even in other parts of the public sector, so teachers, one of our calls is for a definition of long COVID to be written in law, but also for it to be classed as an occupational disease, particularly for those professions that can be shown to be, the definition is that it needs to be twice as likely that if you do that profession that you get COVID or long COVID.
Because it's not evenly dispersed, right?
It's not at all. And so if you look at the most recent data from the ONS, it's interesting that healthcare is there and so is social care, but actually top of the pile is education. And the most number of people as a proportion of a profession that have long COVID is in education. So I think there's really important lessons for the public sector that can apply then to the private sector. And it comes in two forms. First of all is guidance to employers about how to manage this. One of the things that is really, really important in the recovery from COVID and long COVID is that whole, and this is so sort of nebulous, but really important, it's the listening to your body. It's the resting. The phased return to work, which is very much often a part of sort of healthcare plans that you might institute in a workplace quite naturally, actually can have a very detrimental effect on some people if they're feeling that it's not the right time. And so medically, actually, there's a reason to do this. And when employers listen and understand that and give those employees that complete time off, not 1 day a week, not a few hours a day, but actually the complete time off, they're more likely to recover sooner. And now in the public sector, that really matters because we've got workforce challenges left, right, and centre. But they're calling it sort of the great retirement. Even in the private sector, there are lots of people who have decided to sort of pack it in, do something else. Like there is this turmoil going on, which could well be very interesting for the country's future. But we don't want it to be for negative reasons of them not being able to recover from something like this.
Yeah.
And so I think what the government now needs to do is class it as an occupational disease. The Health and Security Agency are looking at this now. There is a committee called IAC that is looking at the data and will make a recommendation. But key to that is that the DWP, which is the department who are the ones who will make the decision, need to then say, well, if that's what the recommendation is, then we agree. And it's worth saying there are other countries, Austria, for example, France, Spain, who have already declared it as an occupational disease.
Okay.
And that means that they get compensation and guidance, and that's really important.
So can I ask some prickly questions here, playing the devil's advocate for a moment? I'm going to start with you, Dan. You're a psychiatrist, so
Yes.
I've no doubt seen this coming. But how much of long COVID? And I ask because we're talking about employment. A lot of employers will think, it's all in the mind, slightly work shy. How do you answer that as a doctor with a?
So I think the first thing to say is that we have for a substantive part of the long COVID cohort, we have biological markers and explanation, which is that there is a chronic inflammatory process in play, and there is a physical. There's now a tangible physical manifestation, and we have that. We also have, obviously, in a very small cohort, within the long COVID group, a group who've had severe, their bodies have been ravaged by the illness, and they were in hospital in ITU or with for many months, and that is a small cohort. But there is for large sections of people with long COVID, there is a biological explanation of that there is something going on. But what you can't do with any long-term or chronic illness is completely disassociate the physical and mental health aspects of that. Because if you look at anyone who's got a chronic and enduring illness or for example, let's say someone with multiple sclerosis or something along of that type, there is always a mental component to that.
And that's to say how we think about our disease and how we approach it mentally can make a big difference to the disease itself.
So saying there is a mental component to illness is being realistic, but that's not downplaying the fact that there is a physical process going on, and it's about recognizing that part of the recovery is also supporting those people who need support with psychological therapy, perhaps in some cases as well. So that should be part of the care pathway for those who need it.
Right. Okay, let's then move on a little bit to children. So the report touches on children. All we've been debating so far is really about adults. Tell us a little bit about, Debbie, children and how it's impacted children and what we need to do to help them through. I mean, children generally in this pandemic have had quite a hit with lockdowns affecting their schooling, et cetera, et cetera. I know from my own kids that that's the case.
Absolutely. And then you put on top of that to have a chronic condition that in some, again, we had some really tragic cases where children weren't able to get out of bed, and the parents were there describing how this daughter or this son had been involved in this football team or this dance group or was doing all this and was competing in a chess team and then they virtually couldn't get out of bed, and the real anxiety for the parents, let alone the kids, about what this was going to mean for them for the rest of their lives. Will they recover? What will it mean for them in the future? What will it mean for their education? How will it put them back? And all these things, and we haven't really touched on nearly enough.
Yeah.
Children on the whole haven't been affected in terms of physical illness by COVID, but what we were hearing in terms of the impact of those that had got COVID and then went on to get long COVID was very, very profound. So thinking about the research that needs to be done, we also need to have a better understanding of how it's affecting different age groups as well.
So it is for children, it is a very small proportion of children who are impacted. We should say
small
that
numbers who get sort of symptomatic COVID, it's less, and then of those who get long COVID, it's less. But it does seem that when it happens to them, it can be very severe. And then you add to that a big pressure on schools, on parents to get attendance up.
Yeah.
And you get a sort of perfect storm of, schools against parents, when actually what you need is, in the same way that the advice for the adults is rest and recover, the same applies to the children. The other thing that's very unhelpful, I think, is that when we talk about the symptoms of COVID, we already know the symptoms of Omicron are actually quite different to the original. And with children, it was always different. The symptoms that children get are very often more sort of rashes, for example, very high fevers and that kind of thing. Slightly different to what the adults got. And so it was very badly publicised. The answer, I think, is sort of twofold. Is one, the recognition that it does affect children. And in those cases, again, the guidance is important for schools. How do you manage that with the family? But also, we need filtration systems in schools to stop kids from getting COVID in the first place. If you don't get COVID, then you don't get long COVID. It's quite simple. And that applies to adults too. But because in schools, and I think there are, good reasons why we need to absolutely have them. I used to be a teacher. My goodness me, I can't imagine what it was like for my colleagues being online for all the time. And they're now starting to take their exams. It's a nightmare. Absolutely keep them in school. But recognise for some of these kids, we can protect them better, and in the form of HEPA filters in every classroom. And that's one of the recommendations that we make in this report.
Let's move on again to long COVID and the law. I think we have touched on this a little bit. The key recommendation there for you guys is that it's formally recognised by the law, right?
Formal definition.
A definition.
Definition and recognition. Yeah.
And some people would say, well, if you do that, it's going to play to all the psychological bits.
All I would say to those people is they need to go and talk to someone who has long COVID. It's absolutely debilitating. And I think this is what's been so difficult about this entire debate, is that I think when people look at the symptoms, they think to themselves, oh, fatigue. Well, I've been a bit tired after being a bit ill, or I sometimes get a fever, or, sometimes my body aches. It's just part of getting older, right? Actually, for the people that we're talking about who have long COVID, it is all of those symptoms, but then to a debilitating extent. Yeah. And so as Dan very eloquently said, that when you have these kinds of symptoms, these chronic symptoms for a very long time, there is obviously that psychological component. But I really don't think that we're suddenly going to have this epidemic of benefit scroungers off the back of long COVID. It's actually quite, I would argue, it's hard to fake because it is just so obviously debilitating, or at least the ones we've met. It's really, really difficult. So that legal definition would give them protection. It would bring us in line with best practice around the world. But mainly what we want is those guidance, those guidelines to all employers, organizations. How do you manage this? It allows people, it says to them, your symptoms are real. This is a real disease. It's a real issue that you are living with. It deserves recognition. And I think that's what we're aiming for here, is to get better management of long COVID in society at large.
Okay. So just before we turn to a couple of questions from people who've dialed in, so to speak, have any of the recommendations in your report, have any of them yet been picked up by government? Not
this one yet, although I will point out, yeah, absolutely. And actually we've had, as a all-party group, we've had a lot of success in many of the campaigns that we've run, particularly if we look back at the debate in January 2021, which was the first debate on the floor of the House on long COVID. What we asked for there was NICE guidelines, which have since come into force, and more money for research, which we then got. So I would say to people who have read the reports to look at the recommendations, go, oh, they're very sensible. Give us some time. But I think, we've now proven ourselves to be, very evidence-led as an organisation. We care deeply about, patient voice and the voice of those who suffer with this. I do hope that slowly the government will realise actually the recommendations in there haven't just been pulled out of nowhere. They're all backed up by evidence and are supported by wide parts of society. And actually, we're trying to help, which is what the all-party group has only ever wanted to do.
And I think, as Debbie said earlier, I mean, the past experience is that you ignore these things at your peril, right?
Absolutely.
So a couple of questions from listeners. Well, we've covered some of them. What would happen for there to be an urgent study of potential treatments for long COVID, similar to the recovery trial? Have you guys got an idea of how that might be designed? Is it an institution that needs to be put in charge of it, or a series of institutions charged with?
Probably you'd want a multi-centre trial to do that across a number of centres, and you may have a lead institution, but then you'd be doing it across a number of centres. So you might have, say, Layla obviously would say, it's obviously Oxford, a very leading centre of research. Maybe it might be Imperial, for example, or King's,
some geographical spread.
and some geographical spread. Who went to, but you do need that, and then you get that and have a multi-centre trial. But I don't think it would probably be the place of the APPG to design that trial. It would be for the clinicians and the researchers to come forward and say, this is what we need to be looking at.
But I do think political pressure does have its place in getting the money in place in the right places for I think it would be just so powerful if Boris Johnson said, this is really serious, and in the same way that he cares deeply about COVID, he cares deeply about long COVID. I don't think we've heard very much from Boris Johnson at all. We hear a number of different ministers express their sort of alarm and say that they are very worried about the impact it's going to have in their particular briefs. But then that doesn't seem to be followed up by that much urgent action, which was the question that you posed. I think there is a place for the Health Secretary in particular to push on this and to say to Jenny Harries and others who are in positions perhaps to push other parts of the research councils to say this is going to be important for our economy. This is going to be important for the future health of our economy as we recover from this pandemic. It needs to be made a priority.
We already know that the health inequalities across the UK are leading to a fall in productivity of £13.2 billion a year, just because of the huge amount. And that's before COVID and long COVID. So if there's nothing else, this should be an incentive for them to put some investment in it. 100 million against that sort of figure.
So this isn't a question from the readers, but it's an important point. We've only mentioned health inequalities. I think that phrase has come up for the first time. I mean, long COVID does hit different groups.
Yeah.
Do you want to talk a little bit about the health inequalities?
Well, we know that structural inequalities were really laid bare from COVID, and then that has then been replicated in terms of the prevalence of long COVID as well. So we know that areas like mine in the deprived northwest of England and in Greater Manchester have been really hit bad. And we know that occupations, low-paid occupations in particular, as well as those that are going to have more exposure to COVID are likely to be particularly hit. We also know that Black, Asian and minority ethnic populations are more likely to be exposed because, again, of the structural inequalities that they're exposed to in life as a whole. So it's a perfect storm for exacerbating what was a bad situation with the inequalities that we have. Our life expectancy is flatlining, and in deprived areas it's actually falling backwards. We are the only advanced economy other than the States where this is happening. It's not that we've reached our peak life expectancy, it's because political choices have been made that allow and enable the inequalities. And unless we do something proactively to address it, it's going to keep on getting worse.
Yeah. So both in Britain and America, those data look pretty troubling.
Yeah.
So this is from a listener. So recent tweet from the Equalities and Human Rights Commission on what might be done for long COVID to be recognised as a disability. Is that how technical?
I have to say, I mean, that tweet was just so ill-conceived because I should say, so this is a tweet from the Human Rights Commission that then said it was not a disability. Right. And it was just bizarre because actually we had heard repeatedly from ministers in the debate that we'd had on long COVID that actually you don't have to wait for a diagnosis of long COVID in order to seek support. The definition of if something is a disability or not for the purposes of accessing benefits is about the effect it has on your day-to-day life. Have to say, it's one of the reasons why we've been deeply concerned about the removal of testing for ordinary people, because it's, fine to say to people, well, you can go into Boots and spend whatever, 20 quids if you want to prove with a lateral flow that you've had COVID. But actually, for a lot of people, that's something they can ill afford. And then down the line, if in a year's time you're still having symptoms and you need to sort of prove in some way that you've had long COVID in order to prove that it's a disability, I think that was really ill-conceived. So my understanding is they've rowed back. Okay. They've said in some cases it might suggest that it could be classed as a disability, but I think what it points to is the fact that they just don't understand long COVID.
I think it may come down to the actual definitions under the 2010 Equality Act, which was quite limited in the definitions of disability, wasn't it? Yeah. And I think that's where it may be hampered. But having said that, exactly, I mean, it was incredibly narrow in terms of the disabilities that were included in that. But
So we've got another question in from Rebecca, who was asking about what do we know about long COVID clinics? I haven't been able to access one in my area. I've been living with long COVID for over a year.
Oh dear.
What's our advice? What's our advice? To harangue their GP?
Harangue their MPs.
Harangue their MPs.
Yes. Yeah. I know that Oldham's doing well.
Do you agree with that as a doctor?
Yes, I mean, I think there does need to be great. I mean, I think political pressure. I think what we discussed is right. That if you bring political pressure to bear, that will help to focus the NHS. And now that the Health Secretary has a much more direct role with the NHS again, rather than being setting a mandate every year and actually being, I think there is a much stronger role for political pressure. But we also there is more that we need to do to, throughout the NHS to tackle the variability in commissioning for long COVID, and that is one of the challenges. We've got some good areas that do it, have quick referrals, and an awareness amongst the healthcare professionals about what those referral routes are. There are other parts of the country where there are real problems.
Well, that's a challenge for the NHS with a lot of...
And Paul, I think we need to acknowledge that there are also other conditions that are becoming overwhelmed by this. So, for example, the pathways for ME, some of them have been used in some parts of the country as also the pathways for long COVID. And what we're hearing from people who are suffering with ME is that they are also finding long waiting times because it's the same professionals, because it's similar skills, who are being pulled in different directions. And the answer to all of this is better treatments, but it's also a recognition that that workforce in the NHS issue, needs to respond to this too.
So another question in from David. It's David. It's quite interesting. Are we counting long COVID yet, or are we relying on ONS data still?
Yeah. No,
it's a little bit rude about the ONS. I quite like ONS data, but is he getting on?
The ONS data is a survey. It then gets extrapolated, and there's always issues with that, but it is something that we at least have. We have always called for long COVID to be counted in the same way that COVID was sort of counted and the case numbers are reported. Right. And the reason for that was partly so that we could make sure people understood it was a consequence of this pandemic. It's sort of the forgotten pandemic within the pandemic is long COVID. And to make people aware that, whilst the case numbers in one go up, the other one does too. And so it's an incentive, particularly among the younger generations, to get vaccinated.
Okay.
I think there is a disease register, international disease register now as well, so that will help with it.
Yeah, I mean, my guess is that the international studies will help enormously if we use them in Britain. Like, the NHS isn't always best looking overseas.
But that said, it is what we have control over here. America thinks that this is such an issue that they are allocating $1 billion to researching and supporting people with long COVID. And I think that just puts it into perspective, you know, how little we are doing.
You're asking for 100 million.
100 million. I think that is reasonable in the context of how big this issue is for our economy.
Okay. So we're at time. Very last thing, Layla, as the chair, what's next for the APPG going forwards?
Well, we continue our work, and it has been the most incredible 2 years. It was set up very quickly as a response to this. I think it has been so wonderful to work so very genuinely cross-party and to achieve what we have so far. The message to give out to people watching today, especially with long COVID, but on the other issues that we've covered as well, is we're not about to stop. The pandemic is not over for so many people.
Yeah.
And on long COVID, we will continue to press. We've had hearings also on the COVID inquiry, which is ongoing, and we take a particular interest in. Let's see if new variants emerge. We are very interested in the international dimension. We continue to take hearings where we're looking across the world at where else has got best practice. And what we've always set out to do, and it continues to be our mission, is we want to help this country through and recover from this pandemic. So let's see when that's going to be, but it's not this year. We are very much still in force and continuing to work this year and probably into next year as well, I'd imagine.
Well, I'll thank you on behalf of both myself as a journalist and my colleagues. You guys have been enormously helpful as a body throughout the pandemic. And I think it's absolutely right to say that the pandemic isn't over. And I think probably we should end just with the thought that the disease is sweeping through North Korea today, really, you know, just as it did sweep the West in 2020. And so that's a pretty terrible thing, really, when you consider we're 2 years on and that nation, for all its peculiarities, is
Very vulnerable. Yeah.
very vulnerable indeed.
Yeah.
So thank you very much and good evening.
Thank you.